Well, hello everybody. I'm Dr. Jamnadas. I'm an interventional cardiologist here in Orlando, Florida with cardiovascular interventions. And today's presentation is on coronary artery disease in South Asians. And this is a very important subject because there's not much literature on this. So I really wanted to expand on this. So I hope you all enjoy this presentation. If you like the presentation, I would like you to subscribe to my channel and give us a thumbs up, and we'll go right into the presentation. So coronary artery disease in South Asians is a huge problem. And we've recognized this for a very long time. Why is it that South Asians who are from India, Pakistan, or Bangladesh, but also South Asians who are living abroad from any of these places, have the highest incidence of coronary artery disease in the world? And this has been a real point of interest and concern. Here we go. The prevalence of the heart disease is so high that in non-Asians, in the United States, there's a 2.5% coronary artery disease risk. But if you look at South Asians who are living here or living in India, it's 7.5%. So it's almost a 3 times higher risk of having heart disease. And this has been documented over and over again. It's a huge problem. And if you look at coronary artery disease in India, in non-diabetic patients, there's 11% coronary artery disease risk, and in diabetics it's 21%. Folks, this is so high that this is of extreme concern to us. This 11%, in my opinion, is actually an underestimation, because that just means that they haven't diagnosed diabetes in the other patients. So what is diabetes? Diabetes is when your blood sugar is already high. Your hemoglobin A1C is high, your blood sugars are greater than 126. But non-diabetics, they contain a lot of pre-diabetics. And one of the things you're going to learn in this slide presentation is the pre-diabetics who have the very high incidence of coronary artery disease. It's the hyperinsulinemia, which is so prevalent in the South Asians, that actually causes this problem. So it's not just diabetes, it's also pre-diabetes. So I made a note down here which clearly states that non-diabetic risk is 11% in India, because many of those actually have pre-diabetes, not just diabetes. So moving on, Indians in the United States have the same rate of coronary artery disease as Indians living in India as well. So this was a study that was done in the UK, Singapore, Mauritius, South Africa, Fiji, and in Trinidad. And in the United States, compared to the Caucasian populations, they have 4 times more hospitalizations for coronary artery disease. They have up to 4 times more complications of the same disease as well. And they have up to 10 times more disease in those who are under the age of 40. I've seen this in my practice all along, that when they get hospitalized, the outcomes are much poorer. And people say that, because the arteries are smaller. They're not smaller. You're born with the same size arteries. It's just that you have more diffuse disease, more disease. So they look smaller. Why more complications? Because they have an underlying metabolic problem as well. So you can have coronary artery disease, but if you have a metabolism problem in your body, then you're going to have a lot of complications as well. So such as non-wound healing is poor, high blood pressure is also present, and just having high blood sugars and high insulin levels changes your risk of having all the complications under the age of 40. So when a young Asian comes into my office and he's complaining of symptoms that are suggestive of coronary artery disease, almost invariably my studies are positive. I will find that they indeed have calcification in the arteries, they have coronary arteries. You don't take this lightly. Do not take this lightly. So I'm very aggressive in young Asians. So these studies are well documented. And if you look at urban Indians, have the same rate of coronary artery disease as overseas patients. So rural Indians have 50% less coronary artery disease. And the question is why? Why is that? What is so different about Indians that are not living in the cities but living in the rural areas? And there are lots of reasons for this, predominantly to do with diet, lifestyle, exercise, and stress. What we also find is that Indians who are living in the cities have a 25% heart attack rates in those who are under the age of 40. So they present with heart attacks. They don't just present with angina. They actually present with a heart attack. So now let me tell you the difference between a heart attack and sudden death. You've all heard of South Asians who suddenly just drop dead at a young age, under the age of 40, under the age of 55. We all know these people. What happened to them? Well, the mode of death is twofold. Either they can have sudden cardiac death or they can have a heart attack. Sudden cardiac death is an arrhythmia, where they suddenly go into a arrhythmia called ventricular tachycardia. And suddenly they have no blood pressure, they keel over, and unless the paramedics come and give you a shock, you're basically gone. That is sudden cardiac death. Heart attack is caused by a blockage in one of the arteries that suddenly cracked open and a blood clot formed. The artery is now shut down, and now there's no blood supply getting to the heart muscle. The patients usually feel chest pain, pressure, heaviness, shortness of breath, sweating. They'll usually have some sort of prodrome, not just suddenly keel over. They'll actually have some symptoms. And then, if that persists, they can also go into an arrhythmia and then suddenly pass away. Or make it to the hospital, but they've got a lot of pump damage, their heart muscle is damaged, and then they die of low blood pressure and what we call pump failure. So arrhythmias can occur in a heart attack, can also occur with sudden cardiac death. Sudden cardiac death is caused when you have all the blood vessels being narrowed. So now the whole heart doesn't see enough blood supply and they go into that terminal arrhythmia. That's why we open up blocked arteries. We open them up to prevent sudden cardiac death, prevent arrhythmias. So this disease, so far you can see in Asians, is very malignant, presents as sudden cardiac death or myocardial infarctions in a large number of patients, and many times they're under the age of 50. So all the more reason we need to be very, very vigilant. And what are the risk factors? The biggest risk factor is this one here called metabolic syndrome. And I'm going to talk more about that in a few seconds. But you've all heard about high blood pressure. Well, high blood pressure is also caused by metabolic syndrome. You don't just get high blood pressure. There's always a reason for it. And the third cause is smoking, then diabetes. Well, diabetes is a metabolic disease. So as I said in the beginning, if you have pre-diabetes or you have diabetes, the risk is the same. Now, that is a key thing that I've said today. Whether you have pre-diabetes or frank diabetes, it's the high insulin levels in these patients that cause the disease. You only define diabetes because the sugar level is now over a certain arbitrary 126 fasting. But the underlying pathology is still the same. The high insulin levels cannot control your sugar levels anymore, so the sugar levels start increasing, and when they reach a certain point, say, oh, you're a diabetic now. But actually, it's the high insulin levels that you've had for years and years and years that causes all the damage to the arteries. And I've covered this all in my video on the bittersweet truth, which is linked below. You all can please look at that because that will give you a great idea on the difference between prediabetes and diabetes and how malignant it is. Then I've listed hyperlipidemia as a cause as well, but only certain types of hyperlipidemia. When you have a high triglyceride, low HDL, which is also related to your sugars. So it's important that we look at your lipid panel, connective tissue disease, which you know of, like let's say you have lupus, then you have a tendency to have blood clots at any site where the artery is ruptured. So connective tissue disease causes the arteries to become smaller, and if they rupture, you're more likely to get a blood clot in it. Obesity. Obesity is listed separately, but obesity is related to metabolic syndrome. Because what makes you obese in these patients is the high insulin levels. Because the insulin's job is to take all your calories and put them into storage. So that's going to cause fat gain, and that causes obesity. So if you look at these obese patients, again, I've covered that in my talks before. Obesity is created by a hormonal change in your body. So that even if you only consume 2,000 calories, if your insulin levels are running high, you're going to gain weight because everything that you're eating, a large percentage of it is going to go into storage. So it's important to understand that they're all linked to this metabolic condition, obesities. And then increased abdominal hip ratio of 0.85. Now, this is very important for South Asians. What's important to understand is if you look at a South Asian, they're usually not that overweight. So if you look at them from the back, they look pretty slim. But the moment they turn sideways, you'll notice that their stomach is sticking out. Look around you. Look at the South Asian patients. They have abdominal obesity. It's all in the belly. Now, where did this come from? It comes from excessive carbohydrates, excessive sugar, which under the influence of insulin has to be put away into storage. You see, you can't have glucose floating around in the blood. So we have insulin that immediately takes it out of the bloodstream, and in the liver, the insulin converts the sugar, particularly fructose and glucose, into fat. And in the liver, it becomes fat. So that's why you get a fatty liver. It stores it. And when the fat stores are saturated in the liver, it moves into the pancreas. From the pancreas, it moves into all the fat around the inner organs. That's why you have a belly. So you look at somebody and they have a belly, but the rest of them is not fat. The arms are nice and thin, the legs are nice and thin, the neck is nice, but they have a belly. They've got insulin resistance. They probably are pre-diabetic, or they may already be a diabetic. They probably have a fatty liver, and their insulin levels are probably high. Yet, if you go to the standard charts and look at the body mass index, you say, oh, is he overweight? No, he only weighs 145 pounds, for example. But he's got a belly. Then he's got a problem. So therefore, the belly sticks out. The hips are nice and narrow. That's trouble. Now, the obese patient who has fat all over, he is in trouble too, but not as much as this. This is very malignant because the type of fat that is generated in the liver from excessive carbohydrates is very inflammatory. So if you do a biopsy of the fat that's in the belly, that biopsy will show a lot of inflammatory molecules in it. And inflammatory markers in the blood will be very high versus the ones who are very obese, but then you do inflammatory markers on them, or if you do a biopsy of the fat, you don't see much inflammatory cells in them. So those are what we call metabolically healthy obese patients. So it's not just obesity, it's where the fat is. And South Asians, look around, you will see it's all in the belly, you're in trouble. That is a major red flag. So we'll find that in general, Asians have fewer of the traditional risk factors. And the paradox is that a blood pressure that is well tolerated in a Caucasian, let's say 140/90, is not well tolerated in a South Asian. So the risk to your vascular system starts at a much lower blood pressure. South Asian, you need not good blood pressures. You need perfect blood pressures, 130/85. The body mass index for Caucasian, ideal 25, South Asian 23. Go to the charts, check your body mass index. Make sure it's down to 23. That's your metabolism. That's where you need to be. We are in a crisis right now among South Asians. So if you look at the rural population in India versus the urban population, you'll see that the urban population's body mass index is much higher, 24 to 25. And you'll say, well, that's not more than 25. Yeah, but that's by Caucasian standards. But for standards in India, for example, that's still too much. And if you look at these patients, they all have abdominal obesity. They all have that bad fat generated from excessive carbs and sugars and insulin resistance. And the hip to waist ratio is 0.99. And they have a sedentary lifestyle in the cities versus in the rural population, the body mass index is only 20. Hence, they have better health. The abdominal obesity is much lower. The hip to waist ratio is usually less than 0.95. And they are non-sedentary. They're very active. They walk a lot. They were walking 3-4 miles minimum twice a day, and they're doing a lot of physical activities. So that explains a lot of the difference between the urban population, the rural population, and what they're eating as well, and how much sugar they're consuming. Diabetes is so much more prevalent in the urban population for the same reasons. It's to do with the diet. Eating too much sugar, too much carbohydrates. So let's look at diabetes then. In the United States, the prevalence is only 5.3%. Well, I shouldn't say only, it's still too much. But in India, it's 12 to 14%. Now, just understand that 80% of the Indian Hindus, for example, are vegetarian. They're vegetarian, and yet they have such a high incidence of coronary artery disease. So this is misconception that if you're vegetarian, you're immune. No, it's the carbohydrates and the sugars, and it's the diabetes. So diabetes and pre-diabetes stand out as the major risk factors for coronary artery disease in South Asians. If you can sum this up in one sentence, then why do South Asians have such a high incidence of coronary artery disease? It's because of diabetes and pre-diabetes, abdominal obesity, metabolic syndrome. Hence, you have all these problems. So it's diabetes, pre-diabetes, hyperinsulinemia, metabolic syndrome. And this causes them to have high blood pressure, high triglycerides, low HDL. And they have a normal or just slightly elevated LDL, the traditional risk factors that you all know about, the bad cholesterol LDL. And look, it's all the way at the bottom. It has very little, if any, effect in South Asians. So the high triglycerides are caused by high sugars, high insulin levels. The low HDL are caused by the same thing. Hypertension is caused by high insulin levels, which blocks nitric oxide, so it makes your arteries not vasodilate, and hence you develop hypertension. So you can see that the root cause, get to the root cause of the problem. Root cause is diabetes and pre-diabetes. Now, diabetes, you can pretty much check it out. You go to the doctor's office, they're going to check your blood sugar and say it's high, or your hemoglobin A1C is over 6.5. But how do you diagnose pre-diabetes? So we're going to talk about that in a second, about how we diagnose pre-diabetes. So insulin is your problem. What causes insulin secretion? Sugar. Bottom line, it's the sugar. Sugar drives insulin to go up, number one. Why do you become resistant to insulin? Because you're eating too much sugar, too much carbs. Carbs also cause the blood sugar to rise and your insulin to rise up as well. Okay, so it's too much carbs, especially carbs without fiber. That means processed carbohydrates, which we'll talk about in a little bit more. Processed carbohydrates made into flour. Anything made from a flour is poison until proven otherwise. So these things that drive the insulin have to be addressed in the diet. And if we look at, as I mentioned before, 50% of South Asians overall are vegetarians. Okay, and non-vegetarians have the same rate of coronary artery disease, not the meats. If you have fats that come with the meat, and if that meat is not from a farm that fed the animals with grains, then the omega-6 levels are going to be okay in that fat. That fat is probably okay and not that detrimental to you. But we've blamed saturated fats. Please look at my video on the fat lies. The fat lies covers all the misconceptions about fat, what type of fats are really bad for you, and what types of fats are actually innocent. But if you look at saturated fats in vegetarians in South India, they say that, oh yeah, there's too much coconut oil. It's not entirely correct. You see, even coconut oil in India has changed from virgin to refined coconut oil. Anything that's refined, anything that's processed, anything that's centrifuged, anything that's heated up, anything that has been heated and cooled again will have trans fats in it. And worst of all, and this is the take-home point for you, the worst oil is vegetable seed oils. So these are all refined vegetable seed oils, extremely high in omega-6, which is pro-inflammatory. Now, of course, it's part of our essential fatty acids. We do need omega-6. We do need omega-9 because we don't make them. But we don't need so much of it. And our diets have completely been transformed because now we consume way too much vegetable seed oils. So what are vegetable seed oils? They're made from seeds. Now, why are they so bad for you? Well, multiple reasons, because those seeds have a lot of chemicals in them to protect themselves from predators, because they want those seeds to actually grow and perpetuate the species. So they contain in them substances that the consumer will not like and actually will hopefully not come back and take more seeds away. But in India, there's vegetable ghee. So that's a total misnomer. Ghee is ghee. It's saturated fats that's manufactured from milk products. Okay, so that's the butter, as they call it. Vegetable ghee is purely made from vegetable oils, whether it's made from soybean oil or peanut oil or sunflower seed oil or canola oil. They're all processed. They call them vegetable seed oils. Well, there's not one of those things are vegetables. They're all seeds. So you're eating an oil that's made from those seeds, cottonseed oil, for example, soy oil. It's a waste product. Cottonseed oil was a waste product. I cover that in my talk on fat lies as well as other lectures. These are all waste products that somebody decided, let's make a profit on it. Let's use it and let's feed people with these vegetable seed oils, which you're not supposed. Look, until the turn of the century, we did not consume vegetable seed oils because we don't have processing ability. If you look at the solvents, the heating process, and you go to one of these plants where they make vegetable seed oils, I tell you, you will not consume any vegetable seed oils at all. This is extremely important. So your cottonseed oil, your palm oil, your mazola corn oil, it's stated, your soybean oil, your sunflower seed oil, all of these. Look at the consumption. And as the consumption of these is rising. So why are we using so much? Well, all processed foods have these oils because it makes for dryness of the product and a very long shelf life. Because of the long shelf life, processed foods use these oils. The processed foods are processed in and of themselves. They've been stripped of all the fiber and they've been powderized. And then they add the final poison, which is the vegetable seed oils, to give it longevity. So you can see that it's a perfect creation. It's the perfect creation of a food that's not going to go down as a healthy meal. So carbohydrates and sugars, okay, are very high in both populations, vegetarian and non-vegetarians, right? But the vegetarians will consume far more wheat flour, chickpea flour, of course the vegetable seed oils, sugars, sweets, and all these refined products. If the product doesn't look like that in nature and it's been transformed into something else, don't touch it. That's what's driving the metabolic process. That's what's driving the premature coronary artery disease in the South Asian continent. So Asians in the United States, they eat United States foods. They eat US foods also. And they go to exercise. And they go to the gym as well. But they also consume these other products. So long as you're consuming the other products, and then the rest of the time you're eating some salads as well, and you're adopting a reasonably healthy diet, the fact is you still got all the bad stuff inside you as well. It's like having the perfect diet, but you're still smoking. So the perfect diet doesn't undo what smoking does. Similarly, having a mixed diet where you eat some Asian foods, but you're also eating American foods, the American food's not going to protect you, especially the healthy American foods. Now, of course, a lot of us also consume some of the processed foods of the Western society, which is also just as bad as all these things that I'm talking about today. So in order to reduce the risk, you need to first and foremost know that do you actually have the disease already or not? So that's called detection. And then we treat it and we reverse the metabolic disease that you got. So what's early detection? So these patients come to me, they're in their 40s and they want to know, am I at risk? Well, I say, well, you may already have the disease. It starts, I told you, 10 to 15 years before you get your diabetes diagnosis or coronary artery disease. You're already working at metabolic syndrome so that when you get your heart attack, you've actually earned it. It's terrible. It's terrible. So the first thing I do is I do a coronary calcium score. And a coronary calcium score is a low-grade CT scan of the coronary arteries. If there's calcium buildup in those arteries, you know you already have the disease. Calcium equals hardening of the arteries. Calcium equals atherosclerosis. So that's the first thing that I do. I'll show you some pictures of that. And then I do a blood test. And the blood test I do is called the Kraft test. And that monitors your insulin level and your glucose level. So basically, you just like your glucose tolerance test, you take some sugar water, but instead of just measuring your sugar over the next 1 hour and 2 hours and back down again, I actually measure your insulin levels as well. So sugars may be good, but at the expense of very high insulin levels. Once I have that, I say, okay, you're not a diabetic because your sugars are within range, so I cannot call you a diabetic, but look at your insulin response. It's way off the mark, and therefore you need to sensitize your body to insulin now. You need to go on my diet and other measures, including fasting, very important to restore the insulin sensitivity. And of course, I've done a video on this one as well, which is tagged at the bottom. So please watch that one on fasting and fasting for survival. And for South Asians, this has been part of our culture. We'll talk more about that in a few minutes as well. But this is extremely important. And then we have a CRP level, where it tells me how much inflammation is going on in your body. We have the homocysteine level, very important because it is linked to atherosclerosis. Your A1C is related to sugar. And look, I didn't put 6.5. 6.5 is for diabetes. But if you want to see whether you have insulin resistance, you're going to be between 5.7 and 6.5. And then I look at your triglyceride HDL ratio. So oftentimes, even if I don't have the insulin levels, if I look at the A1C, which is an easy test, everyone should be able to get that. I look at the triglyceride HDL ratio, greater than 2, then I already know that you probably have insulin resistance. Sometimes I don't even have to do the Kraft test on those patients. I look at the body, I see that the belly is the problem, and I've made my diagnosis. You need to make lifestyle changes. You want more proof? Then I'll do the Kraft test on you as well. So this is a coronary calcium scoring study. It's a CT scan. So as you can see over here, this is a CT scan. It's a cross-section of the heart. And this is the aorta right here. And coming off the aorta is the left main coronary artery. And this is the left anterior descending artery arching forward. And this is the circumflex artery going at the back over there. And here in this particular picture, you see all these white spots here. And this is the calcium, because remember, x-rays don't go through calcium. They're like bone, right? So you see all these big white spots on the CT scan. The scan takes literally 5 minutes to do. No IV injection. Just come in, just lie down. So long as your heart rate is nice and steady and less than 65, we can do this. Sometimes we have to give you a beta blocker just to slow your heart rate down a little bit, give you a little tablet, because you want a nice scan, because after all, this is a moving object. So you want to get a nice slow heart rate. But these are further scans demonstrating the calcium. And here, this one here, the left anterior descending artery has so much. And you can score this calcium. So the higher the score, the more dangerous it is for the patient. So the ideal score is 0. And between 0 and 100 is mild, although I don't think it's mild. I think that's moderate. Between 100 and 400 is considered moderately severe, and over 400 it's very severe. So I've had so many patients that come here, they're completely asymptomatic, and their scores are 2,000. 2,500. Oh my goodness, this has been going on for years and years and years. And we don't know when you put on this calcium. And therefore, one, it establishes the diagnosis. But number two, I repeat this study in 2 years. What does that tell me? In 2 years. So if your score was, let's say, 100, and 2 years later it's jumped to 400, then I know that there are still some factors in you that you're building up more plaque. You're making more atherosclerosis. You're making more hardening of the arteries. So you dig deeper, find out, why are you doing this? Do you have a leaky gut? Do you have sensitivities to certain medications? But we can certainly do more investigations here. This is very, very important. Now, moving on, the next picture here is demonstrating on the CT scan what your arteries are going to look like. So here's an artery that comes in the front over here. And you can see there's a plaque of calcium here. There's a calcium here. Look how lumpy, bumpy this artery is. And you can see that it's very thin. It's becoming thin here. So the calcium is in the walls of the arteries. And the actual lumen is thin because there's diffuse disease. Look how thin this is. This one is more dramatic. It's demonstrating all the white spots of the calcium. And this is what the arteries look like. So this is a CT angiogram. So for this test, we inject some contrast into a regular IV, and as we're injecting it, we do the CT scan at the same time. When we do that scan, we can actually see the contrast filling the arteries, and we can see the calcium buildup also at the same time. They are very, very dramatic pictures that we get. And here's another one where we can subtract out the rest of the heart. Beautiful techniques, and you can see the arteries, what they look like, where they are, whether they're completely blocked or not. This is the left entry descending artery. This is the right coronary artery. But this is an anomalous right coronary artery, by the way. This is the right coronary artery. It's coming off near the left main coronary artery. So you can see congenital disease as well. So you can see that the arteries are coming off in the normal place or not. It should be coming off the right cusp, which is usually around here, but this one is not. It should be like this one. You see that this one's coming off the right. And here's the artery. But look at all the calcium buildup in the walls of the arteries. And you can imagine now in your mind's eye how one of these plaques is going to rupture. And the day it ruptures, a blood clot forms inside and seals off the artery. So once you have calcium, the higher the calcium score, okay, the higher the calcium score, the more plaque. The more plaque you have, the more likely that it's going to crack. Somewhere along here, it'll crack. And when it cracks, a blood clot forms, seals off the artery, and now all of a sudden you're having a heart attack. So one day you're feeling good, the next day you're having a heart attack. Why are you feeling good the day before? Because the blockage doesn't have to be a 90% blockage that cracks and then seals off the artery. It could be a minor plaque. It could be a little area of calcium such as this one here. There's no predictability as to which one of these calcium plaques is going to close off and cause the heart attack. The severity of the stenosis does not predict the site of the occlusion. I'm going to say that again. The severity of the narrowing does not predict the site of the future occlusion. That means a minor blockage of less than 50% in an artery can suddenly crack the next day and become 100%, just as well as a 90% blockage that can also crack the next day and close it off. Now, of course, the tighter the blockage, more likely you're going to have chest pains and you're going to get some warnings. But in majority of the patients, there's no warning. There's no warning that I'm going to have a heart attack tomorrow. You wake up in the morning and bingo, it cracks and you're getting a heart attack. Now, when you have a narrowing, and this narrowing is causing you lack of circulation and therefore you're getting angina. Angina means chest pain. You are lucky. You are now lucky. So if you're lucky that you got this warning system, that you had some chest pain, that means you've got a tight blockage somewhere that's restricting the blood flow. Now you can go to your doctor and say, hey doc, I've got some chest pain, and the doctor will do a stress test on you and see that there's a problem, or order a CT scan or some other diagnostic modality, and we'll be able to tell and move you forward. But many of these patients, unfortunately, have no warning whatsoever. They have absolutely zero warning. So here's some more angiograms. You can see in this one, the artery here, there should be an artery right along here. This is called a PDA, and it's missing. So we know that he's already had a heart attack. It's already closed off the artery. And when we do three-dimensional reconstructions, you can see these arteries quite nicely and quite beautifully. It's beautiful imaging. Here's another set of arteries. But I want you to appreciate the disease, meaning see it. Don't just assume, well, I'm okay just because I passed my stress test, because I just told you that you could still have a lot of calcium, you could have minor blockages, have a stress test, pass the stress test, because none of the blockages are more than 70 or 80%. So you only fail your stress test when the blockage is more than 70 or 80%. Now that should scare you. I hope it's scaring you. Because if you have a minor blockage of all over here, let's say a 50, 50, 60, 70, 70, 50, 60, 70, you may pass the stress test. Because you're still getting plenty of blood flow and you're not getting any chest pain whatsoever, and therefore you think you're just hunky-dory because you did your stress test and you passed it. And worse still, you did your sugar test and you're not diabetic, and you go home and then a few years later you get a heart attack and you say, whoa, where did those blockages come from all of a sudden? Well, I hope you're getting a better picture of why that happens. So to reduce this risk, I also do a liver ultrasound. Because if you have a fatty liver, it's part of this metabolic process. Where does this fat come from? I told you, it's the sugar and the carbohydrates and processed foods. Sometimes it also comes because you have a gut problem, intestinal dysbiosis, as I call it, which is the wrong bacteria in your gut. Or it can come from food sensitivities, which cause what is known as a leaky gut, where certain ingredients in your food should not be crossing over into your bloodstream, but they do, and they create a immune response in your body, which cross-reacts with other parts of your body and cause inflammation, and that, of course, causes coronary artery disease. So when these things happen, you get a liver ultrasound and you see it's a fatty liver. Why would you have all that fat in your liver? Well, there you go. That means you have insulin resistance. You need to get rid of the fatty liver. First thing you need to do is get rid of the sugar, and then you need to also gradually do the fasting program that I encourage all of you to do, because that's going to reset your microbiome in your gut and give you sensitivity again to insulin. So you got to do the fasting program. Watch my video on that, and you got to watch what you're eating. So the newer blood tests that are emerging, which are not always covered by insurance, the insulin-like growth factor binding protein, which is very low, increased leptin levels, decreased adiponectin levels, increased sept levels, increased lipoprotein a, and increased PI1 levels. But those are just tests that can be done if people want to do that. It's not often covered by insurance. But the bottom line is, eat whole foods only. If it doesn't look like it appears like that in nature, don't touch it. Don't touch it. Don't eat it. It's got to look like it does in nature. Otherwise, don't eat it. If it's going to stay like that for days or weeks on end, don't eat it. It's probably processed. So non-processed foods, whole foods, high fiber. Why do you need high fiber? So people say, oh, fiber is good for me. It's not just for your bowels and your BMs and all that stuff. You need fiber for your bacteria in your gut. Number one, because the bacteria is what's going to consume the fiber. And these bacteria liberate good nutrients into your body. And they improve your gut health as well as your immune system. But also, you need high fiber because when you eat foods in the intact state with all that fiber, you produce less insulin. Because the food is not processed, it's got still all the fiber in it, you're not going to evoke that huge insulin response when you eat it. Because when something's processed, it goes into your stomach and then goes to the duodenum. When it goes to the duodenum, all as processed food already, it's already semi-digested. The body thinks that, oh my God, I got to deal with all these nutrients all at once that's coming in. I'm going to produce a lot of insulin because I got to get rid of all the stuff that's coming in. So the K cells in the duodenum start producing a ton of signals to the pancreas to say, I'm going to need lots and lots of insulin for this because there's all this processed food that's come down. Foods that are still in their natural state will also evoke an insulin response, but because of all that fiber, the response is much smaller. So it's much attenuated. So that's why you want the high fiber foods. Fermented foods are very good for you because it's good for the bacteria in your gut, because that's good for your immune system. So I encourage a lot of yogurt, some kefir, sauerkraut, kimchi, and that improves the diversity of your microbiome. And I think there's a lot of research going on about the microbiome. Your microbiome changed when you came here to the United States as well. So you got to keep that in. That's why when we go back to our homeland, sometimes we get GI upset. It's all to do with the bacteria. Even if you're eating the right stuff, you'll still notice changes in your stools because of the microbiome changes that are occurring. Measure your blood pressures. Make sure that it's always less than 130/85 because that's a sign of underlying metabolic disease. Lose weight. Bring your body mass index down to 23. People say, oh yeah, you look terrible. No, you look great. Get it down to 23. And do intermittent fasting because that restores insulin sensitivity. It allows the gut microbiome to get better. It improves leaky gut, gives your gut a chance to rest. What are we doing these days? We eat every 2 to 3 hours. We're not supposed to do that. Teleologically, our great-grandparents in India were lucky if they ate once a day. Sometimes they would even pass that because they fasted a lot. And they didn't fast because they didn't have food. It was just a lifestyle. Some patients, I advise them to do time-restricted feeding. That means they eat in a 6-hour window, which is still better than eating every few hours where you're constantly stimulating your pancreas to make lots and lots of insulin. Eating multiple meals a day, bad idea. Okay? Eat infrequently and fast more frequently. So OMAD is once a day meal. This is what I would love to do most of the time. So even if I'm doing one meal a day, 5 days a week, and then Saturdays and Sundays I can enjoy a little bit more, it's still better. Eating once a day allows your body to heal restore insulin sensitivity. You'll notice your blood pressure will get better, your energy levels will go higher, your mental functions are better. And that's a whole new talk that I've given. Please, as I said before, watch my lecture on fasting, okay? Fasting for survival, very important lecture. Okay. One thing that is addiction. I got to mention something about addiction. Because many people want to do this and they start feeling terrible when they start fasting or changing their diets. It's because you're addicted to the processed foods. And don't take this lightly. It's serious. And it happens to a lot of people. And the symptoms that they get when they're not eating, oh, my sugar level went very low. It's not the sugar level went low. It's because you're a junkie. Basically, you're withdrawing from carbohydrates and sugars. Because those sugars go to the same part of the brain, which is related to dopamine processing. So it goes to the same part of the brain as drugs would go as well. So you're basically going through the same withdrawal process, and you'll have the same problems with cues that make you want to go and eat, and you get urges that you want to go and eat that sweet thing. And then a lot of the foods that are processed also have in them certain chemicals that make you addicted. There's addiction molecules in all of these, such as in dairy products as well as in wheat products. There are chemicals in them. They're similar to opioids, and they can also cause an addiction. So watch for addiction. If you do start this diet and you notice that this is happening to you, it'll wear off in a couple of days. Just like the drug addict, we just put him in a room in the hospital. After 3 days, he's detoxed, he's fine, he's gone over it. It doesn't continue forever. So the first few days are the toughest, but you got to make these changes and you got to make them now. Exercising daily, prefer the resistance exercises. That's my preferred mode of exercise. I've got a separate video on exercises. And if your coronary calcium score is very high, I do add aspirin to your medical regimen, because I think that if that calcium cracks and a blood clot forms, at least that clot will not be a big one. It'll just be a small little one, and hopefully you won't even know that a plaque ruptured in your artery. And then I also give my patients with a lot of coronary calcium vitamin K2, because most of us are vitamin K2 deficient, and we know that vitamin K2 deficiency causes coronary calcification. Omega-3 supplements, extremely important. As part of my test, I do the omega-3 panel, and I usually supplement them with omega-3, vegetarian and non-vegetarian. Vitamin D3. This is huge. Vitamin D, people poo-poo it, but it's so important. It controls over 300 metabolic processes in the body, and most of us today are vitamin D deficient because we are indoors all the time. We don't get enough sunshine that our forefathers had, plus the foods themselves these days have less vitamin D content. I sometimes give them a herb called berberine, which is a little bit related to metformin, and has the same kind of effects and does sensitize you to insulin, gives you a little bit of weight loss as well, and it's pretty innocuous. So I like berberine as a supplement in patients who are pre-diabetics and they don't want to take metformin. But metformin, of course, has been shown to reduce the progression from pre-diabetes to diabetes. So sometimes I'll give it to you not because you're a diabetic, but you're pre-diabetic. It also now, latest data is showing that metformin also affects your microbiome. So it's a very important one. And I give it particularly if you have a positive coronary calcium score. Sometimes I give them angiotensin receptor blockers, especially if the blood pressures are high. But remember, when your insulin levels come down, your blood pressure also gets better. I sometimes give them a GLP-1 receptor agonist as well, and these are the names of the drugs. But remember that if I give you a drug of this kind, it's only because I want to change your physiology for now, but ultimately you can do it yourself through diet. Look, this is one of the diseases that can be turned around through diet. Question is, are you willing to do it? Do you have the gumption? Do you have the willpower, self-control to do this? Or are you a junkie now for food and you just can't change? Oh, that's just the way I've been brought up and that's the way I am. Because history will repeat itself. It'll keep happening. You will still get diabetes. You'll be pre-diabetic. And the worst part is that once you get diabetes, then it's not just heart disease. Dementia, huge one. Look around you. There's people with dementia and you wonder, why did they get dementia? It's vascular. It's small vessel disease. It's inappropriate vasodilatation in the brain. Now they're calling this type 3 diabetes, insulin resistance at the level of the brain. Blindness, small vessel disease in the brain. Peripheral vascular disease, atherosclerosis in the legs. chronic renal failure, all related to diabetes as well. This is so important, folks. I cannot overemphasize this. It reduces total mortality as well. All-cause mortality also goes down. If you're going to use drugs, I use it initially, but the goal really is your diet. You really have to change the diet. You got to eat whole foods. And we in the South Asian stores have such a variety of vegetables. All vegetables are amazing, amazingly healthy for you. Now, of course, cut down on the potatoes if you have over diabetes or insulin resistance, because these simple carbohydrates, such as potatoes, are just simply glucose molecules stuck together. They do come with some fiber. So it's not all that bad, but eat whole foods. These are further new drugs, other drugs that I advise some people to try. This new category, SGLT2 inhibitors, I use that for my cardiac patients with coronary artery disease because they do reduce cardiovascular risk by 38%, hospitalizations by 35%, and death rates by 32%. So this is very, very powerful. So what does this drug do? It basically gets rid of the sugar in your urine. So the question is, what's that got to do with such a beautiful reduction in your risk? What it has to do is your total body's glucose load goes down. You're unloading the body of that excess glucose. That's why it really works so well. And remember, besides glucose is not that toxic. It's fructose. So I got to say something about juices. No juice. Juice is processed. There were no juices 10,000 years ago. There were no juices out there. There were no steel mills until the late part of the 18th century. So no juicing, no processed foods, no milling products. And I'm going to give you now my 13 most important points in summary. Lose weight. Avoid all sugar, high fructose corn syrup, simple starch, all mithais and desserts and sweet dishes, snacks, all juices, processed foods, refined products, products made from flour, especially wheat. Stay away from wheat. Barley, you can try some barley or sorghum. Those are alternatives that you can use. Avoid all vegetable seed oils. Prefer ghee, extra virgin coconut oil, omega-3 and butter. Frequent fasting. You must do some sort of fasting program. Stop eating all the time and on the go. Avoid antibiotics as much as possible. Consume fermented foods because you want to take care of the bacteria in your gut. Eat a variety of fiber from a variety of plants. Don't eat too much fruit because they are high in fructose. So eat lots of little of different types of fibers. And then consume organic meats. If you're going to eat meat, chicken, fish, turkey, eggs, all that should be organic so that you don't catch some of the chemicals in them as well as the omega-6s, which I've mentioned before. Make sure you're sleeping at least 7 hours a day. Your gut needs a break. Your brain needs a break. You need a break. And your brain is what's going to heal your body during delta sleep. No blue lights at night after 8 o'clock. Start planning the evening. There were no lights in the caves before. There were no electric outlets in caves before. And that's when you were manufactured. That's when you were made. Your body's blueprint is from those days. Resistance exercises, high intensity interval training is what I recommend for most patients. They feel so much better when they do that because that's what you're supposed to do, even teleologically. You're not supposed to run 2-3 kilometers every day. If you run 2-3 kilometers, the saber-toothed tiger would have caught you up already. You can't outrun them. But you can have short bursts of intense activity. So you just quickly sprint and get out of the way, or quickly swim across the lake, or you quickly climb up a tree. I mean, those are what I call high intensity exercises, short bursts of activities. Stress management, very important. Okay, you must find at least one pleasurable activity on a daily basis. Something that gives you intense pleasure. Everyone's different, but whatever it is, find it. Find that one, and then have a stress management program. And we are very fortunate. We have yoga, we have our spirituality that we can engross ourselves into, and no more than one alcoholic drink a day, 10 minutes of direct sunshine every day because of the vitamin D. And behavioral therapy means be on the lookout. You may be an addict. Look for the cue enablers and avoid addiction foods. So be aware. How do I feel when I eat this? Why am I eating this? Am I fully aware of what's going on? Or am I eating involuntarily? and just as a reflex, both mental and physical, just grabbing the stuff and just eating it? Am I addicted to it? And if you honestly look at these things, you will find that you can make the changes. So I hope you all enjoyed this, but it scares me that the incidence of coronary artery disease in South Asians is so high and climbing. And there's not a week that goes by when I hear that somebody lost their son at a young age. Parents are still alive, and they may be in their 80s, and the son is in their 50s and lost the son. It's a tragedy what's going on. And, throughout school, nobody really gave us an adequate explanation as to why this is happening. But I hope that I have shed some light as to why we are particularly prone to so much premature coronary artery disease at a young age. And don't buy this theory that it's all genetic, that's it. It's not. If it runs in families, it's because they probably eat the same thing and behave the same way, and they metabolize their life in the same psychosocial ways. So I hope this is helpful to you. If you like this, please don't forget to subscribe to my channel and look for some more videos, and press the thumbs up button. Thank you. Good health.